Good morning. Thanks for joining us. Welcome to the Virtual Education Chronic Pain Summit Series, Part 2, presented by Johns Hopkins University School of Medicine. My name is Dr. David Simpson, and you are tuned into the live session called Practical Strategies for Assessing and Managing Neuropathic Pain. I am a professor of neurology at Mount Sinai School of Medicine in New York. In addition, I'm also the director of the Clinical Neurophysiology Laboratories and director of the NeuroAIDS program at Mount Sinai Hospital. I've been the principal investigator for many studies, including the treatment of neuropathic pain in patients with painful neuropathy and treatment of spasticity with botulinum toxin. Before we get started, I would like to remind our audience that I will be taking questions in real time throughout this presentation. You can send me your questions anytime during the program through the box in the lower left-hand side of your screen. And now let's get started with the lecture. The first order of business is to define pain. And the International Association for the Study of Pain has provided a definition which incorporates some of the key issues. Pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Key points here, both sensory phenomena and an emotional reaction, and not just actual damage such as a broken bone, but potential tissue damage. The patient may be concerned that they have tissue damage even if we can't detect it or diagnose it. There are many ways to describe and classify pain, and here's one of the classical ones. On the one end of the spectrum is nociceptive pain, at the other is neuropathic pain. And what do these mean? Nociceptive pain is caused by damage to tissue. For example, a sports injury, such as a fracture of the arm, postoperative pain, arthritis. On the other side, we have neuropathic pain, which is caused by primary damage to the nervous system, either central or peripheral. For example, polyneuropathy, like diabetic or HIV neuropathy, postherpetic neuralgia, the pain occurring after shingles. Then we have some mixed disorders that may be a combination of nociceptive and neuropathic. And you'll notice in both categories we see low back pain, one of the most common pain syndromes which may combine elements of both. Here again we see a slightly different classification of types of pain, now getting toward underlying pathophysiology. We see nociceptive pain again, which I've told you is damage to tissue, which ultimately excites pain pathways. Inflammatory or joint pain. Inflammation, for example, such as that due to rheumatoid arthritis. Neuropathic pain, we see here the lightning bolt indicating damage to either the peripheral nerve or the spinal cord. And then we have this interesting and somewhat difficult category called non-inflammatory or non-neuropathic pain. This is defined by the negative, that is the absence of the other definable pain categories. And in many cases, we don't clearly understand the cause of this pain syndrome. What are some examples of this? Well, one of the classical ones is fibromyalgia, in which we can't clearly define tissue pathology in patients who report diffuse muscular pain. Chronic tension headache is another example. Or some of the irritable bowel syndrome pain disorders. We can't clearly define pathology, but these patients report pain. And we'll come back and talk more about this. One of our greatest areas of interest in my research and clinical group is neuropathic pain. And here you see an example of peripheral nerve damage. I've mentioned examples like diabetic or HIV neuropathy, postherpetic neuralgia, in which an individual develops herpes zoster or the shingles rash, and then may have prolonged neuropathic pain that can last for many months and even years. Neuropathic pain is extremely common, and here we see some survey data that was generated by Bennett some years ago, which breaks down the general categories of neuropathic pain states in the United States. We see that the largest single category is low back pain. And I imagine many of you listening to this lecture have yourselves experienced low back pain, one of the commonest causes of missed work and national health care costs. Amongst other definable neuropathic pain syndromes, the single largest category is diabetic neuropathy, with postherpetic neuralgia being a close second. And then we see an assortment of other syndromes here, including cancer pain and spinal cord injury. When we think of neuropathic pain and begin to look at some of the underlying causes, there are numerous potential contributing causes. For example, diseases that I've mentioned earlier, infection, such as HIV, neurotoxicity, such as that due to chemotherapies, tumor, metabolic disease like diabetes, trauma, obviously, such as surgical trauma or mechanical trauma. A patient puts their hand through a plate glass window, injures their median nerve. That's neuropathic pain. We cause pain iatrogenically through our treatments like surgery and chemotherapy and radiation therapy. And then there are many genetic diseases, inherited causes of neuropathy, which can be looked into with various assays, including genetic testing of blood. I've mentioned diabetic neuropathy is the single most common cause of, other than low back pain, of peripheral neuropathy in the US. And there are risk factors in patients with diabetes that increase the risk of neuropathy. One of the most important is age. As individuals get older, they have a greater risk of neuropathy, and that's true for many diseases. The duration of diabetes. The longer patients have been diabetic, the greater the risk of neuropathy. Poor glycemic control. It's well known that tight diabetic control improves the course of neuropathy. Then there are a number of vascular risk factors contributing to diabetic neuropathy, including hypertension, cholesterol, and triglycerides. Similar risk factors for stroke and MI. The second common cause of neuropathic pain, postherpetic neuralgia. Pain that persists at least 3 to 4 months after the initial rash. Again, very common. 1 in 5 Americans will develop herpes zoster, that is shingles, at some time in their lives. At least 20 to 30% of those with shingles will develop postherpetic neuralgia, and age is the most important risk factor for this disorder. It is a very painful problem. Symptoms include burning, throbbing, intense electric-like pain, and allodynia, that is when you just touch the skin, patients experience severe pain. I've mentioned age, severity of rash, and other risk factors, including a painful prodrome. There are many medicines that we give patients that cause neuropathy. In HIV patients, the antiretroviral so-called D drugs, D4T, DDC, DDI, all cause neuropathy. Fortunately, we see far less use of these drugs today.